starting. All attendees are in listen-only mode.
Good evening. This is Dr. McSherry and Dr. Elizabeth Prusak. It is August 4th, 2014, starting the August webinars. Tonight we're going to be doing two things. We're going to be going over a caseless mock oral, and that's going to be the first half hour. And the second half an hour, I do need a volunteer to solve the case of the day. So if you know you have a very good sound system and audio and a microphone and headset, please send me an email text and I will put you on tonight to be on the hot seat. Okay, so, hey Liz, your headset is humming a little bit. I don't know if it's, maybe you
Let me take it out and put it back in.
Yeah, that sounds like a good idea. Hi Rachel, how are you?
Good, how are you, Dr. McSherry?
Good, good. You like to be the first person of the year? How's that? So the first mock oral. Isn't that wonderful?
Yeah, oh, sure. Yes, very wonderful.
I know, it is really wonderful. Okay. All right, I'm going to go ahead and give, Liz is working on her headset here.
Better now?
Yeah, I think it's okay. Are you still there, Liz?
Right, good.
Yeah, it sounds a little bit better. It was just like making a humming noise. I don't know if it was maybe, I think it's better. Yeah, I think it's better. Okay, Liz, can you take over the mouse and see if you can move it and you can move her case list? There you go, good. Okay, Rachel, you ready?
Yes, I sure am.
Okay, Liz, are you ready?
Yep, I'm ready.
Okay, go ahead. You guys can start.
All right, perfect. Hi, Rachel. How you doing tonight?
Good. How are you?
Okay, I'm perfect. Okay, so first of all, tell me about case number 2.
Case number 2 is a 30-year-old G1P0 who presented to the emergency department with acute pelvic pain, vaginal bleeding. She had a positive beta HCG, and upon performing an ultrasound, they found an adnexal mass of 3 centimeters. And the patient, so we decided to take her to the operating room to originally perform a laparoscopic salping or removal of the ectopic pregnancy, and then actually in the OR, before we even started, she decompensated and became hemodynamically unstable. So we immediately decided to perform a laparotomy, and then we performed a salpingectomy.
Okay, perfect. So let's say that this patient is not 30. Let's say that she's 65 and she's not pregnant. Can you tell me a little bit about the OVA1 biomarker blood test?
So if she was 61, that would put her, I mean, she had acute pelvic pain, vaginal bleeding?
Nope, that's not my question. I'm actually asking you to tell me about what's the OVA1 biomarker blood test.
So the little bit that I know about the OVA1 biomarker test is that it's the gynecologists use it as a better screening method.
No, actually, the GYN-oncs don't use this test. Tell me what age of woman that it's indicated for.
I'd have to look that up. I'm not very familiar with that biomarker.
Okay, that's fine. Tell me a little bit about ultrasound. How would you start off by differentiating a benign appearing tumor from a more of a non-malignant type tumor? Give me several things on an ultrasound that you would look for.
Okay, so on an ultrasound, things that would determine whether it's a benign looking or not, we would see if it is a the size of the tumor would, first of all,
what
would
size?
be so if we had a size, for example, of less than 5 centimeters on that 65-year-old, that would be a better prognosis.
Okay, what other features that indicate a malignancy possibly?
Oh, malignancy would be, for example, if it had solid components, if it had excrescences, if it had thickening inside of the tumor, and of course if it was a complex tumor.
Okay, and what would you say, what do you mean by complex?
So if it complex being that it's not a simple cyst, it's not just a fluid-filled cyst. It has blood component, it has a solid component, it has excrescences, it has.
Okay, all right.
Yeah.
So let's say that this patient was diagnosed with ovarian cancer. What are some favorable prognostic factors for ovarian cancer?
One of the favorable prognostic factors would be that you would catch it early in time. So if it was still small, not metastasized, if you were able to obtain a gynecologist to come in and do staging, if you did not rupture the tumor inside of the pelvis and you were able to remove it without rupturing it, and if the patient was able to have access to
okay. Thank you very much. So let's go down to your cases on, I want to take a look at, you have one of an adnexal mass coming up here on the bottom. Oh, let's see, ectopic, you got a lot of ectopics here.
Yes.
All right. Let's see, I'm not seeing the case that I had here, but let's see, I'll go back up. So you have a case actually up here that I'd like for you to talk about. It's actually a...
This one? This one, maybe?
Yep. Yeah. So tell me about this case, this 26-year-old that you took to the operating room.
Yes, so this is a 26-year-old G2P2 who presented to the emergency department with severe pelvic pain. In the emergency department, they had performed a ultrasound which showed a hemorrhagic cyst and also a hydropyosalpinx. The patient had an elevated white blood cell count and she had a fever. And at this point, we for pain
What's a fever? What's a fever definition?
Greater than 100.4.
Okay.
Degrees Fahrenheit. And so we decided, because of the pain, to admit the patient. She was placed on IV fluids, she was placed on analgesics and IV antibiotics.
What antibiotics did you give her?
She was placed on cefoxitin and I can't even think of it. What am I trying to think here? Doxycycline, 100 milligrams via IV, and cefoxitin as well.
How much? What's your dosage for cefoxitin?
I'm sorry.
Not a dosage.
No,
okay,
I know. Sorry,
move on.
I'd have to look
Keep
that up.
going.
I would have to look that up.
Okay. Keep going. So what did you do with this patient?
We admitted her. We placed her on IV antibiotics and analgesics, and the pain was resolved, and she defervesced, and their white blood cell count.
Okay, so you're taking this patient to the operating room, and you decide you have your instruments ready, and you're going to do a laparoscopy on her. Okay.
Okay.
I'd like for you to tell me about what type of entry do you do for your Trocars? Do you do various? Do you do direct? Do you do open umbilical entry?
Sure. So what I do is from umbilical, or actually the base of the umbilicus, usually inject with some analgesic, local analgesic, and then using a scalpel.
Wait a second. You inject with some? What exactly do you do?
I apologize. That was very unprofessional. So I use 3 mLs of 3 milliliters of lidocaine, 1%, and inject at the base of the umbilicus, and then using a number 11 scalpel, create a 0.5 incision in the base of the umbilicus, and then I use the Very's needle attached to the CO2 gas, and I do enter that way directly, and then the lower entering pressure of it demonstrates that we're intraperitoneal and low entering pressure, and then I allow the abdomen to create a pneumoperitoneum. Then I remove the Very's needle.
Okay, so you can't enter. Unfortunately, you try 3 times, but you just can't seem to get for some reason you can't get insufflation with your Very's. What's your next step?
What would that have happened? Because why?
You can't get insufflation. It's not, the pressure is not increasing. What do you do next? The patient's under anesthesia.
Okay, so are you trying to say that I'm not in the right space? I didn't get into.
I don't know. I'm just saying that you can't get proper insufflation. What's your next step?
So after attempting various times, I would see if my partner who's operating with me would like to attempt to place the Very's needle and see if they can get in. And are they able to get in?
Nope, you're not. You're working with a surgical tech.
Okay. So then I would try to perform an open Hassan method entry.
Okay, tell me about how you do that.
Sure. So I would grasp each edge of the umbilicus with a towel clip, and then I would use the scalpel to create an incision, and then and also I would then enter into the fascia, and then a direct visualization of the placement of my Hassan trocar.
How do you compare the open umbilical entry with, let's say, a closed technique in terms of entry failure and organ injury?
So the Very's needle is it's a better entry because later on there's less possibility for having a hernia in the trocar site. Although under direct
I didn't ask you about that. I asked you with regards of entry failure and organ injury.
So the open Hassan has better visualization, so that's why some people prefer it. But actually, for organ injury, if a person has a previous surgery, they can have just as much injury with the open Hassan than you could with a Verres needle. But the Verres needle is a preferred method of entry.
Okay, tell me the surgical steps that you do in the operating room when you're going to take a patient for a laparoscopy case, starting with your consent procedure.
With my consent.
So you're going to take a patient and you're going to take her for a bilateral salpingo-oophorectomy, and she is 48 years old and she is perimenopausal.
Okay, and why am I doing the bilateral?
You have bilateral adnexal masses with chronic pelvic pain, and they're getting larger.
Okay. So first I would perform a history and physical on this patient, so I would know their past medical history and to see if the patient also needs a medical clearance. And then I would perform a physical exam, so I'm familiar with the patient.
Okay, I would like to know what you place on your consent.
Oh, sure. So I would consent the patient for the exact procedure. I would explain the procedure in layman's terms to the patient, so to her understanding, and then I would consent her that the risks and benefits of the procedure and alternative therapeutic treatment. So I would say the risks of a you said laparoscopy or laparotomy? I'm sorry.
Laparoscopy.
So the risks of a laparoscopy are risk first of anesthesia, which has its own risks, then risk of bleeding, risk of needing a blood transfusion, which also has its own risk of reaction, hepatitis B, C, and HIV. I'd explain to the patient there's a risk of infection, there's a risk of damage to bowel, bladder, and adjacent organs. And I'd also explain to the patient there's a remote risk of needing a hysterectomy, and of course a very remote risk of death. And I would make sure the patient understood all this. She can read the consent herself.
Would you would you tell her anything about ureter injury?
Oh, sure, that would be adjacent organs. So yes, I would mention to her adjacent organs being bladder, bowels.
And what would you quote to her the incidence of an incisional hernia after a laparoscopy?
It's low, but I would have to look that up to be able to tell her the exact percentage. I don't know that off the top of my head.
And what would you tell the patient about trocar site metastasis if the mass ended up being malignant?
It's a very low possibility, but
What's the percent?
I don't know off the top. I'm going to have to look that up.
Okay. All right. So we went over about 15 minutes. Okay. So I want to go ahead, and I know that we kind of did a round of basically blitzkrieg here. Okay. So just to start off with, you know, that's how that they're going to shock you on the boards.
Okay.
They're not going to actually say, okay, just let's do your case. Let's ask just about your case. I mean, you were probably pretty shocked when I started to go from an ectopic to the OVA-1 test, right?
Very, yes.
Yeah, yeah. Believe me, that's the reason I did that to you is because that's what they did to me on the boards. They started asking about OVA-1, and I was like,
oh my God.
Okay. So just so that you know, all these questions can basically be gotten from either, you know, your practice bulletins, the committee opinions. If you're weak on GYN, I would read Williams' GYN. If you're weak on obstetrics, read the obstetrics book, okay? Or if you're pretty much a good generalist, you can supplement with up-to-date. Okay, so the OVA-1, it's a biomarker. Okay, the test is indicated for women who are older than 18, have an ovarian mass that warrants surgery, and have not yet been referred to a GYN oncologist. So that's where you kind of made the mistake. Now the score, you have to determine a score, and if it's greater than 5, then it suggests a malignancy in a premenopausal woman, and if it's greater than 4.4, it suggests a malignancy in a postmenopausal woman. I was asked this question on my board exam. Okay, wow. So that's the answer for that one. Okay, now I asked you a bunch of questions, I believe now, about what were the features of an ovarian mass that was
malignant or benign.
Malignant, okay. So one of the things that's favorable prognostic factors, okay? So think about this simply, okay? A patient that would have a good prognosis if they had ovarian cancer, it would be somebody young, right? Somebody with not a lot of medical problems, and that's called a good performance status. Somebody who has a tumor that's well differentiated. So first you have to compartmentalize your head when you answer these board questions, okay? It's very important that you think clearly and that you kind of divide it into categories. So whenever you think of something, you think of patient, tumor, and then if there's any metastasis, right? So the patient's young. She's got no medical problems. She's got a well-differentiated tumor, and then you kind of talked a little bit about, did it rupture, whether or not that there's no metastasis present, right? Right. Is there any residual tumor, after that? So you're not going to have to know a lot about GYN-onc. The test is not going to be heavy on GYN-onc, but what it is going to be is they're going to have to at least know that you know the basics of, well, what are the risk factors for bad prognosis for ovarian cancer? And I mean, and you should know that, okay? Yep. Now, the last question that I asked you is about sonography, okay? We all use sonography as gynecologists, so we have to know what's bad and what's good. You did a fairly good job on this. You got the 5 centimeter, malignant tumors. They're generally solid, large, have thick septae, papillary projections, or neovascularization, okay? Now, one of the things that you can add is that, if the patient is, let's say, very obese or you can't seem to see the mass very well, you can always get a pelvic MRI to give you better characterization, okay? I think that you did fairly well on the questions. Like, you took it a little bit good. Your speaking process, though, is a little bit, as I say, there's a little too many ums and a little too many uhs, and you don't seem you don't seem professional enough yet. But I think that you're going to need a lot more practice. Okay. So as much as you can get on a webinar, or if you can go to a study camp or the mock orals, that's going to be your best bet. The incisional hernia. Okay, I asked you 2 things about incisional hernias and trocar site metastasis. Those are important because you do laparoscopy. You need to be able to quote to a patient, well, what is their risk? So their risk is about 1%, okay, with an incisional hernia, okay? And, obviously it's going to be more if it's greater than 10 millimeters in diameter. Now with trocar site metastasis, that's becoming a big deal because, as in my hometown here at Brigham and Women's, we had the whole lawsuit of the morcellation of the carcinosarcoma of that young doctor there, okay? Yep. So these types of things in laparoscopy are going to come to the forefront, okay? So trocar site cancer metastases are low, and they complicate about 1%. So if you think that something is low, I would do the whole 1%, 3% rule that we kind of, I wouldn't say I don't know, but, you can kind of guess, and you knew. I mean, I bet if I would have pressed you for a number, you probably would have said 1 or 2%, if I'm guessing, right? Right. So you did pretty good in that, okay? And I think that you just need to be a little bit more logical in your thinking, okay? Yes. Yes. So let's see. What else can I? Yeah. You're welcome. You're welcome. So let's see. I think I've got about another 10 minutes with you, actually.
Yeah, you do. Go ahead.
Good. Okay. So I got about another 10 minutes with her. So let's go ahead to another case. Let's take one for abnormal uterine bleeding. That's always a good one because there's a really good practice bulletin on there that you need to know backwards and forwards. Okay. So tell me about case number 35.
Case number 35 is a 45-year-old G2P1 who presented initially to my office with abnormal uterine bleeding, and then we performed a ultrasound which showed endometrial polyps, and I wanted to obtain an endometrial biopsy before proceeding with any further therapy, so we got an endometrial biopsy which was benign. And then because of the polyps on the ultrasound, we decided to perform a hysteroscopy, DNC, and polypectomy, and the pathology was benign endometrium and benign polyps.
Perfect. Give me some of the systemic abnormalities that could cause a woman to have abnormal uterine bleeding in a 45-year-old.
So those would be
Wait a second. Hold on.
Yes.
So just the way that you spoke, I want you to go back and I want you to speak to me like a physician that deserves to be board certified.
Okay. So the...
So wait, okay, so there are many causes of systemic abnormalities. Okay?
Okay, yes.
Now,
yes.
Go ahead.
Okay, thank you very much. There are many causes of systemic abnormalities, such as leiomyomas.
That's not a systemic abnormality. I'm asking for an endocrine systemic abnormality, not a structural problem.
Sure. So that would be then a thyroid problem could cause abnormal uterine bleeding.
Okay, whoa, whoa, whoa. A thyroid problem is something that you say to your niece, okay, who's a layman. Hypothyroidism, hyperthyroidism.
Okay.
Move
Hypo
forward.
and hyperthyroidism, and also anovulation, perimenopause, and a prolactinoma, and a hormonal problem such as, any general...
That's really, this is sounding worse and worse.
Yes,
So,
I know, gosh, darn it.
No, it's okay, you're starting, okay? So I want you to just, when we talk about abnormal uterine bleeding, you want to separate the causes, okay? So you have systemic abnormalities such as the endocrine problems, and you have coagulopathies, renal failure, hypo and hyperthyroidism, and diabetes and pituitary disorders. So one of the things that I think is great about Dr. Wall's course is that Dr. McSherry always says, give me 5. Have 5 in your brain, and then you'll remember 3 for the exam, okay?
Yes.
So you have to have, it's almost like when she asked me in our camps about, give me the causes of like early postpartum hemorrhage. I mean, it had to be bam, bam, bam. Like you shouldn't even have to think. So this is something that you deal with every day. You see women coming into your office. You know this. I know that you know this. It's just that you get nervous when you think about that you're in a testing situation. So separate this. Okay, you have anatomic lesions. You have your systemic abnormalities, such as your chronic renal failure, your endocrinopathy. So separate it out in your mind. And then for each one, have at least 3 to 5 that you can just rattle off that you don't even need to think about. Okay? Now, what's the mnemonic that you're going to use? How do you evaluate abnormal uterine bleeding?
Palm
What do you use?
The mnemonic palm
And they want to hear that, okay, because that's on the ACOG practice bulletin. So you say, I use Palm Cohen. I look at and then go through, what's Palm Cohen stand for?
Okay.
Tell me.
So pregnancy-related
No, the P does not stand for pregnancy.
Well, I'm drawing, I can't believe this, I'm drawing a complete blank.
Okay.
So,
okay, that's okay. All right. Tell me a little bit about the differential diagnosis for postcoital bleeding.
the differential diagnosis for postcoital bleeding is trauma. Could be trauma, vaginal or cervical trauma. It could be cervical cancer. It could be from endometrial cancer or endometrial problems, thickening or endometrial hyperplasia, and it could be from vaginal atrophy, and it could be from a polyp, an endometrial polyp, or a cervical polyp.
Okay, all right. You mentioned cancer a couple of times and trauma like 3 times, but that's okay. So you can have, like you said, invasive cancer, a cervical erosion, an endocervical polyp, an infection such as cervicitis. All right? So say it a little bit more logically one more time. Put all your answers together in your head and tell them to me one more time.
So the differential diagnosis of postcoital bleeding could be malignancy, could be infectious, could be...
Don't repeat could be each time,
okay,
by the way.
Okay, sorry. So my differential diagnosis for postcoital bleeding would be malignancy, trauma, infectious causes, and structural causes.
That's beautiful. Bravo, okay? And what do you do for a woman who has persistent postcoital bleeding? Tell me your evaluation and management of the patient.
First, I would perform a history and a physical on the patient. On the physical exam, I would perform a speculum exam and inspect the cervix,
Okay, everything looks normal with the cervix. There's no structural problems present.
Okay, I would perform, make sure the patient's pap smear is up to date, and if not, perform a pap smear. I would perform cultures for infections such as gonorrhea and chlamydia. I would also perform to see if she has trichomonas, yeast, or bacterial vaginosis.
Everything turns back negative, actually, and she is up to date with her pap, but she still continues to have unexplained postcoital bleeding. What is your next step in management?
I would perform a ultrasound, a pelvic and transvaginal ultrasound to make sure there's no structural abnormalities.
Everything is normal with the ultrasound.
So then I would perform a hysteroscopy, DNC, to see if there's anything inside of her uterus that is causing this.
Insurance has declined paying for your hysteroscopy. What is your next step in management for this patient?
Is this patient postmenopausal?
She's 45.
45. If she was complaining on inspection, I did not see vaginal atrophy?
Nope.
Okay. So she's too old to have a coagulopathy causing this, and that we haven't discovered yet. And so let me see, what will we do next?
It's the only test you haven't told me that we do every day on women who have abnormal paps. You got to do a colposcopy, dear. A colposcopy exam is for unexplained postcoital bleeding. All right?
Yes, yes.
That's you. I mean, that's okay. So that's the answer for that. Okay.
Okay, yes.
All right. So that's good. Okay. So just, you need to just learn how to answer a little bit better. Okay. But other than that, you did pretty good on everything. You're on the right track. You're starting early and you're practicing. When's your exam?
November 3rd through 7th.
Okay. November. Okay. Okay. That should be fine. Okay.
Okay, thank you very much. I appreciate it.
Rachel, just hang out 1 second. Didn't have anybody to volunteer. You want to go ahead and do the case of the day too?
Sure. Yes.
Poor girl.
No, I need to practice. I need to practice.
It's good. It's painful right now.
Yes, yes.
But it's better. It's better, Dr. Consoli. Really. Like, you're benefiting tonight. Okay.
Thank you.
Okay, 1 second.
My meanness, you're benefiting.
This is the second. Let's do the first one. This one's a little bit harder. We'll give her the hard one tonight. Actually, not that one. Yeah, this is the hard one. All right.
Oh, the answers are there, Dr. McSherry?
Well, she won't be able to see them.
Oh, she won't. Okay.
Oh, no, of course not. And not unless we want to, whenever you're ready for me to reveal the answers, I will.
Okay. So I can't reveal. You reveal, right?
Yeah, I'll reveal. You can change the slide. You can just go to this little arrow down here, Liz. I'll be here.
Yeah, I got.
Okay. Okay, go ahead, Dr. Do you want her to read, Liz? Or...
Yeah, have her read it. Have her read it.
Okay, go ahead, Dr. Consoli.
Okay, so here we go. A 27-year-old presents for her annual physical. During her bimanual exam, you palpate a 5 to 6 centimeter adnexal mass. What is your differential diagnosis? My differential diagnosis is an ectopic pregnancy, an ovarian cyst, and a tubo-ovarian abscess, a malignancy.
So you've kind of already gotten yourself in a small hole, Dr. Consoli, because you started off poor by picking the thing that's it's the least likely, okay? How many times, and just be honest with me, how many times have you actually palpated an ectopic pregnancy?
Never in my life.
Okay, I never have, okay? And I did a fellowship in GYN, okay? And I've never palpated it, okay? So you can keep it on your list. It's not bad. It was a little bit surprising that I heard that first, okay?
Yes.
Now,
yes.
You kind of screwed yourself over by just saying, like, an ovarian cyst, okay? So, I mean, give yourself some room here,
Okay.
You know, give yourself some room. So think of, you know, what we always say in medical school. When you think, when you hear hoofbeats and you're in Africa, you can think, you know, zebras, but not in Indiana where I'm from, okay? You
Yes.
think horses, okay?
Yes.
So let's do a little bit better about what we can say by just give me anything with a pelvic mass, okay? You can do this, okay? Think about pelvic mass. What's the most common? 90% of women have these.
A leiomyoma.
Yes. Okay, good. So start off with that. Now,
Okay.
what's going to be your next thing that you're going to palpate?
It would be a cystic structure, a cyst.
Yeah, I mean, you know, you can go into it a little bit more. Like, you know, you can say, you know, it would be, you know, a cyst, such as a simple cyst or a hemorrhagic cyst or an endometrioma. You can buy yourself a little bit of points with that. That's fine.
Okay.
What other things would you say that, you know, would be like masses that you can feel? And remember, you don't have to just keep it to GYN.
Oh, okay.
I mean, that's going to make them think that you're kind of thinking outside the box, right? So at the end, you want to talk about GI, right?
Sure.
So you were right with a tubal ovarian abscess, you know, but they didn't give you anything in the case line that talks about that she's like a sick septic patient. All right?
Right,
So
right.
just be a little bit careful with what that you pick first, okay?
Right. They did say annual exam. That's true.
Yeah, I mean, she comes in for her annual, and it's like she's like got like a death trap of a TOA, right? So let's talk about, you know, what did, and Dr. McSherry's list is good. You know, it does include ectopic, you're right, but, you know, I just maybe wouldn't talk about that, you know? I think hers is good, but, you know, just think extra. Like, so you can also think of like some sort of a mass in the colon, right?
Yes.
So anything that can create any sort of a bulging in the belly.
Yes, okay.
Right? So think of it that way. So you really have to have a little bit better different. And I don't know, I didn't see an adnexal mass. I mean, she didn't list a fibroid as one of them, but it could be mistaken. You know, also,
Sure.
I mean, you know, you have, you know, diverticula. I mean, that sort of stuff, you know, in the colon setting. So, I mean, that's something that you can think of to list. But I think that, you know, you really need to look up, you know, what's your differential diagnosis of like a pelvic mass, okay?
Okay, yes.
All right. Okay, so again, we're going to go back to, oops, I'm really sorry. So you have a 27-year-old, she just comes in for her annual, and you palpate like a 5 to 6 centimeter adnexal mass, and what's your then initial management for this patient? What would you say?
I would want to know first, as part of the history, if this is bothering her, if she has any symptoms with this mass, and then depending on, and also because it is so large, 5 to 6 centimeters, I would want imaging. So I would order ultrasound, transvaginal and pelvic ultrasound.
You're a gynecologist.
And of course a pregnancy test, of
Exactly.
course.
So, you know, that's one thing I know that, and you know, we forget that all the time. It's like the most forgotten thing is the darn pregnancy test, you know, but always just remember you're never wrong, unless she's postmenopausal, okay?
Yes.
You're actually never wrong in a pregnancy test, okay?
Okay.
Yeah. So you get the pelvic transvaginal ultrasound. Okay, so ultrasound, it confirms a 4 centimeter simple cyst. Okay?
Yes.
What are you going to do next?
In this young patient, it's 4 centimeters. I would observe if it's not causing any significant symptomatology. I would observe her and repeat the ultrasound and see if it resolves on its own.
Okay. Perfect. So you can repeat the ultrasound. You know, I should have waited to click this, but it's when would you repeat the ultrasound?
Usually we say 8 weeks to 12 weeks.
Yeah. Yeah, I think that's a pretty good thing. Now, you know, also, you wouldn't be wrong if you actually said, you know, technically in a mass that's less than 5 centimeters, and if it's a simple cyst, technically 4 centimeters is still considered a physiologic size. So you're also not wrong if you say, like, the only reason I'm telling you this is because let's say that the examiner says, well, do you always have to repeat the ultrasound in this? You know, and they start to press you. Well, I mean, technically you don't. If it's a 4-centimeter simple cyst, there's no additional treatment that's required actually for this.
Okay.
So just remember that, okay?
Sure.
All right.
Okay.
Go ahead, Dr. Pencils.
Thank you. She returns in 1 year, and the repeat ultrasound shows a 12-centimeter cystic adnexal mass. What is your management? Oh, and I already did the ultrasound. That's what's showing me the 12-centimeter cystic adnexal mass.
That's where it comes into.
So I would ask her if she's having any symptomatology with this, and then I would consider offering her surgery, because at greater than 10 centimeter, I mean, this is a large cyst, and this thing cystal adnexal mass. I may even want to perform an MRI to see what exactly what exactly is going on with this cystic adnexal mass.
How do you perform your MRI? What kind of MRI are you going to order, and what do you order with it?
I order a pelvic MRI, and with it, I order.
Do you order any contrast?
Oh, yes, you can use that. You can use it with. Yes, I would order an MRI with contrast of the pelvis.
What kind of contrast?
Gallidium.
Gadolinium.
Excuse me, gadolinium.
Yep, you're going to order it with gadolinium, and then you're going to make sure that they have. I mean, this is a young girl, but just make sure that their kidney function is, I mean, it's a requirement in my hospital, so I actually don't even really do much before I order my pelvic MRI, but you're supposed to order, you know, just to make sure that the kidney function is okay before that you give contrast, right?
Yes.
Okay, good. Okay,
Yep.
So talking about how would you proceed? Would you try to take this mass out laparoscopically, or would you go straight to laparotomy? What's your kind of consent and discussion with the patient?
So I would discuss with the patient that we would try initially to remove the cystic mass laparoscopically, and I would use an endo-catch bag, of course, and then open the abdomen, that trocar site to the 10 millimeters.
Whoa!
And then,
okay. What kind of bag are you going to use? You said you're going to use an endo-catch bag, right?
yes.
But are you aware that the upper limit for the regular endo-catch bag is 7 centimeters?
No, I'm not aware of that. 7 centimeters. I thought it was larger.
Well, there is a second type of endo-catch bag. What type of endo-catch bag are you going to ask for?
So I would have to look that up. I would have to look that up before I could answer
So
that.
there's a thoracic surgery. There's an actual one where they do lung resections. So there's
Okay.
two types, and this is good for your future. I mean, I just know this because, like, I take out, like, 14 or 15 centimeter masses, right, laparoscopically. So there's actually a thoracic endo-catch bag. So the upper limit, I believe, is like 15 or 17 centimeters.
Oh, okay.
And then the smaller, the regular endo-catch bag, it's like 7 or 8 centimeters is the upper limit.
Oh, okay.
So that's good. So tell me, do you know, give me 4 types of germ cell tumors. I know, these really suck. I'm sorry to torture you.
No, it's not torture. So let me think here. So let me just think about this. Germs. Okay, so we have dysgerminoma.
Good.
We have teratoma, so immature, mature teratoma, choriocarcinoma.
Oh, I have a quick question. Okay, so you have a mature cystic teratoma, right? And typically that they're slow growing. They have one area of growth which protrudes into the cavity. Okay, do you know what the area of growth is called that the pathologist specifically needs to look at to check for malignancy in a teratoma?
No,
By
I
the
do
way,
not.
do you have any dermoids on your case list?
No, I do not.
Okay, so you have no dermoids. Well, okay, then I'll let you go for this one.
Okay.
It's called Rokitansky's protuberance. Okay, and they asked me that on my exam because I had a dermoid, and maybe that was just a really complicated question, but the pathologist actually takes a look at that, and that's the area that they're looking at to check for malignancy.
Oh, wow.
What's the rate of malignant transformation in a dermoid in women typically that are older than 40? Remember, it's low, so what are you going to think of?
So low, I'm thinking of 1%.
Good. I told you 1 to 3% in the last one. What's the most common type of malignancy, type of cancer that it would be?
You mean from the malignant teratomas?
Yeah.
The immature is the malignant.
Yeah, I know, but what type of carcinoma? Is it going to be squamous? Is it going to be mucinous? Is it going to be neuroendocrine? What's it going to be?
Oh, neuroendocrine.
So
Neuro is the
squamous cell
malignant.
carcinoma comprises 80% of the malignant cases.
Oh, okay, I didn't know that.
Okay. All right, good. All right, so let's go back on the case. We're diverging a little bit. Okay, so you primarily do laparoscopy, right? And then in what situations would you not do a laparoscopy in a patient, maybe?
Considering how I would probably, if I wouldn't do laparoscopy, if I suspected the patient, if it was not actually ovarian mass, it was actually a fibroid, and then I would definitely recommend laparotomy in a fibroid because we're not allowed to use the morcelator anymore. But I would...
Wait, okay, so you... Okay, sorry. Okay, I got to stop you there.
Okay,
so
please.
You're not allowed to use the morcelator anymore, so you don't do any laparoscopies for removal of fibroids.
That is correct. At our hospital, that is correct.
But you're aware, though, that you can still remove a fibroid without using the morcelator, right?
Sure. I'm sorry. I see what you're saying. Just like a myomectomy. Absolutely. Yes, absolutely.
Okay, and you can still put the uterus in an endocatch bag, right, and bring it up to the top and morcelate it inside the bag, correct?
Correct. Yes, I do know that. Yes,
okay.
Correct.
Okay. No, I just wanted, because you said a really strong statement there,
yes,
and
I
it
know.
just
Yes,
bothered me. Okay.
Sorry. Thank you. Yes.
All right. Let's move on. Okay, go ahead.
You perform a cystectomy. The frozen section shows a borderline tumor. What is your next step? So my next step would be to consult.
Okay. And you know what I'm going to tell you.
Yeah, they're not available.
They're not available. They're off on a beach in Hawaii.
Okay, so if they're off on a beach in Hawaii, I would...
You're going to join them, right?
Yeah, exactly, I know, right? I would, since it's a borderline tumor, I would call in a general surgeon to help with lymph node dissection, but I would...
Whoa, is that really the treatment for a borderline?
No.
This is a 27-year-old girl.
I know, I just went crazy.
You're killing me tonight.
Oh, no, sorry, that was completely crazy. So I would finish my surgery. I would take out the cyst. Some people recommend to do a unilateral salpingo oophorectomy on that side, and so I did consult the gynecologist. Wasn't there?
That's what you would do, right?
And I would perform the unilateral salpingo. So she did say that. Good. So you did say that. So that's what I said. Yes. I don't know why I said general surgeon. I just went crazy for a second. Sorry.
That's okay. It happens even to the best of us. Okay. So you took out this borderline, and she's going to come back, and the girl's going to say, "Well, do I need another surgery to go back and to do staging?"
So the answer is no.
Okay. And what's the average age of a patient with a borderline tumor?
Younger than the ovarian cancer population.
Yeah, so just think about it. Wait, just think. Okay, don't get nervous. Think about somebody that you knew that had a borderline tumor that you helped manage.
She was in her 30s.
Okay, I mean the average age is like 40, but you at least you didn't answer 15. Okay,
yes.
So that's good. That's good. So tell me about how are low malignant potential tumors, also known as borderline tumors, how are they differentiated from benign cysts? Like, what do they look for? Microscopically. So when the pathologist looks for them, what do they look for? Okay. Don't say that you don't know, okay, because you do know this. Tell me about the difference between a benign and a malignant tumor, and then think what a borderline means. Just think about the word, Dr. Consoli.
Sure. So it could have some components of that appear malignant, but so it would have not as thick septations, and it could have a solid component. It could be bigger than a benign tumor.
Okay, so it has some formation of microscopic papillary projections. It has mitotic activity that's increased. However, unlike invasive carcinoma, it's the absence of stromal invasion.
Okay.
Okay. Are there any borderline tumors that you know of that do invade the membrane? Do they have any stromal invasion present?
In the borderlines?
Yeah.
Not that I know of.
There are, okay, and they exhibit microinvasion. Okay, so I probably would stay away from that something never happens, because that's almost never, to put a pun on the word, that almost never happens in medicine.
That's true.
Okay,
yes.
All right. Okay, so I don't know if there's anything left here. Let's see what we got left. Oh, okay, perfect. Okay, so how would you manage your post? I think you did a scope in her. I know I went in so many different directions tonight, but I think that you scoped her. Okay, so how do you manage this patient post-operatively?
So if she was laparoscopically, we could consider discharge the same day if she does well. I would...
Okay, I don't like the way that you actually started that.
Okay,
so you right away told me as a board examiner that you're going to kick her the heck out of the hospital because you're already thinking about discharge. Okay,
right, that's right.
I'm thinking about, I have my daughter in your recovery room and she's your patient. Okay, how are you going to take care of her?
Okay, so I would assess the patient and verify that the patient is stable, she's doing well, pain is under control. I would discuss with the patient the findings on the frozen pathology. I would discuss with her what we needed to perform in the OR, and I would explain to her that as an outpatient I would want her to see a gynecologist, and I would evaluate her and basing each case individually. I would see if the patient needed to prolong her stay in the hospital for pain management, or I would see if the patient was adequately pain managed and felt like she could be discharged.
That's better. I mean, don't you think that that's better than starting off with, I'm going to think about discharging the patient the same day?
Yes, thank you. That's absolutely correct.
Okay. Yeah, no, I mean, I think that that's a little bit better. Okay, so good. So we've got about 10 minutes left. Okay, so I would like for you to tell me the course of the ureter.
Okay. So let me think about this first. Okay.
Where are you going to start off with? Okay. So I'm
going to start off with the kidney, and the ureter leaves the kidney, and it proceeds caudad, and then the ureter at the pelvic rim I don't want to say dives down. I shouldn't use that word, right? So I should.
No, you probably shouldn't.
Right. So it becomes retroperitoneal, and then we have on the medial leaf of the broad ligament, and then it courses down between 1.2 and 1.5 centimeters to the internal portion of the cervix and the internal os of the cervix, and then enters the bladder and
Okay, that's really bad. Okay,
yes,
so let's start off from the beginning. Okay, so I want you to do this. So this is the way that Dr. McSherry teaches all her candidates, and this is the way I memorized it. And I mean, and I did my fellowship in GYN, but even me, it's like you just find the ureter, like, because you know how to find it in the cases. You don't sit there and say, the ureter is about 25 to 30 centimeters long. I mean, how many people actually do that during surgery, right?
Right.
But that's how I want you to start. Okay. So, Kate, remember, you're going to do it the same way every time. They're going to ask you, tell me about the ureter. And once, if you can give them like a couple lines that show that you know it, they're going to be like, okay, let's move on. And they're going to give you your check mark and your point. Okay. So if you sound smart in the beginning, they're going to respect you. Okay. So the ureter is how long?
It's 30 centimeters.
Okay. The ureter is 30 centimeters long. Okay.
The ureter is 30 centimeters long.
It courses between the peritoneum, okay, atop the psoas muscle. Okay, so think about, you know what the psoas muscle looks like because you've seen it in surgery.
Yes.
Okay, so it goes above the psoas muscle until it enters the pelvis. And where does it enter the pelvis?
At the pelvic rim.
At the bifurcation of the common iliac artery and the vein. Okay, so now we're going to go through that one more time. So let's repeat. There's only two points you got to get across right now. Tell me them. 1, 2.
Okay. The ureter is 30 centimeters long.
Check. Good.
It courses on the peritoneum atop the psoas muscle.
Okay.
Until it enters the pelvis at the bifurcation of the common iliac vein.
Iliac artery and vein. Okay, good. Now we can start to talk about your medial leaf of the broad ligament. Okay? Then after that, it passes into the medial leaf of the broad ligament. And where is it going to go? Does it go medial or lateral to the internal iliac? You know this? Please just think about, close your eyes and think about your laparoscopic case that you do. Medial or lateral?
Lateral.
Medial. No.
The medial leaf of the broad ligament and then medial. Yeah. Okay, sorry.
So the ureter passes into the medial leaf of the broad ligament.
Okay.
Anterior and medial to the internal iliac artery. Okay, now we're going to go back. So we've already talked about the bifurcation of the common iliac artery. Now tell me about the medial leaf of the broad ligament, and then tell me about your internal iliac. Go.
It passes medially in the broad, on the leaf of the... Okay, sorry.
Say it again.
Okay, so the ureter passes medially on the medial leaf of the broad ligament, and then anterior medial in the internal iliac artery.
Yeah, to the internal. Okay, good. Then it passes under the uterine artery. And you remember that from medical school, water underneath the bridge, right?
Right.
So under the uterine artery, 1.5 centimeters lateral to the cervix, until it courses to reach the trigone of the bladder. Okay, so now let's go back. Okay, so you got medial to the internal iliac artery. Then what happens when it hits the uterine artery?
Then it passes under the uterine artery, and then 1.5 centimeters lateral to the cervix, and then it courses
into the trigone.
And then it reaches the trigone of the bladder. Yeah.
Perfect. Okay. So you really need, it's only like a few steps. Like if you make a list, and if you write it, I mean, if you really want to do it again with me, like we can do it, but like I just want you to do, write it down. Like when we do it now, write it down on your list and just take it with you in your white coat pocket, and in between patients, just look at it. And then, I mean, you can memorize anything. My God, you've memorized thousands of pages throughout your life already. Right. You can memorize a stupid course, like 7 points of a ureter, okay?
Right.
Yeah, so I mean, like you can do this. So where do you think that this ureter can be injured? Tell me three places that the ureter can be injured.
The ureter can be injured near the pelvic brim. It can be injured near the medial leaf of the broad ligament and near the cervix.
I'll accept that kind of. I would say that, it can be injured at the pelvic brim at the level of the IP, because they want to know that when you do like a hysterectomy, when you do your steps, okay, so you take the IP, right? That's where, bam, injury to the ureter.
Yep.
You take your uterine artery, bam, injury to the ureter, right? And then finally, at the uterosacral ligaments, bam, injury to the ureter. Okay, so every time they want to make sure that you know how to be safe. So when you're doing your hysterectomy, and you are, like you're checking, you're looking, like you're taking the uterine artery, but you're like, resident A, resident B, where's my ureter? Where's my ureter? You know, and I know that you're doing it, but you just didn't even tell me that you did any of that. So tell me again, in the steps of your hysterectomy, give me 3 places where you could injure your ureter.
I can injure my ureter near the IP, near the uterine artery, and near the uterosacral ligament. Okay,
and I would actually say infundibulopelvic pelvic ligament, just to like not be, you know, don't be over, you know.
Familiar.
Okay, all right. And then, you know, I know like in our classes and stuff, you know, they talk to us about, you know, the different reimplantation of the ureters into the bladder, you know, the ureter neocystotomy, all those sort of things. So, you know, you're probably going to be asked about a ureter injury on your exam. I was asked about a bladder injury, so I was actually asked to draw a bladder injury and how I would repair it. And so, you know, you definitely want to study those sort of things because they're big into, you know, our most common complications as gynecologists are going to be bowel and bladder injuries, right? And then wound infection, right?
Sure.
So this patient, so again, how would you manage her postoperatively? Okay. So this is a little bit more than what that you discussed, okay? But I was kind of asking you, it was kind of my fault because it's the way that I asked you, because I asked you immediate recovery room. But for the long term, just go ahead and read this so that you get it in your brain so all the other candidates can benefit.
Sure. Chemotherapy and radiation is unlikely to improve the outcome. I would follow this patient yearly with pelvic exams. Fertility-sparing surgery is associated with up to a 15% risk of relapse, usually in the contralateral ovary, but remains highly curable by reoperation and resection. If she completed childbearing, I would recommend removal of the other ovary, tube, and uterus.
Okay. Ooh, okay, here, let's get through. We've got 2 minutes. Go.
A 17-year-old presents with a 10-centimeter solid adnexal mass. What is your differential?
Okay, so remember we got a 17-year-old now. Okay, so think.
So my differential is, again, could be a leiomyoma. It could be, so let me start saying it could be leiomyoma, a benign cyst of the ovary. More rarely would it be...
don't say would it be, just give me one.
Okay.
Don't say would, it will.
Okay, tubovarian abscess, malignancy, and...
What about pregnancy?
Oh, well, I mean, so we're just feeling her uterus, that's what we're feeling?
You know, it's always some sort of a differential, and I don't think that she has it down here, but I mean, you can always, if you can't think of something,
just say pregnancy.
Rattle off pregnancy, okay? And it'll buy you like 2 seconds to get yourself in order, okay? Okay. So these are the things that are important for, you know, a young girl. You're going to have your germ cell tumors, your dysgerminoma. Pheochromocytoma is really quite rare. And then, you know, these other things, sex-cord stromal tumors. And you have to know the different tumor markers for all of them. And I know that we're getting kind of lost on time because I like to pimp a lot. So we're going to go ahead and go to the tumor markers right now. Do you know any of them, or would you like to read it?
I'd like to read it, please. Okay. I do know some, but I'd like to read it.
Yeah.
So LDH, AFP, HCG, and then CT scan of the abdomen and pelvis.
Yeah, because, you know, only because it's such a solid tumor, I think that there is a malignant potential in these. So, you know, you're going to want to take a look at that. So how would you manage this solid mass surgically?
And all the tumor markers were negative, and she just has, it's just a, okay. So I would consent the, a midline incision, collect peritoneal fluid for cytology, fertility-preserving surgery to retain ovarian function. If the ovary cannot be salvaged after doing a cystectomy, I would perform a salpingo-oophorectomy and send for frozen.
Yeah, I mean, it's basically very similar, right, to our borderline case. You know, you don't want to take fertility away ever from a young girl. So, you know, one of the things that they're going to ask you about, and I know that they pimp us on the camps is, you know, what are you going to do if you go in and if you see a mass on the ovary and it's cancer and you don't have a GYN oncologist? They're going to push you to stage the patient. You should not do that.
Okay.
You can always close and save another day, okay? You can always go back in and do it, but do not stage a patient unless that you are appropriately trained to do so. So don't ever let them push you to stage a patient, okay? Because you shouldn't be doing that. Of course, now that I said that, how would you stage her? Well, it doesn't mean that you shouldn't know how to do it, but there's a difference between knowing and doing. Okay, so I assume that you probably don't exactly know how to stage her, but you can tell me how, I mean, how would you think, I mean, you've been trained in residency, how do you think that a GYN oncologist would stage her?
So he would stage her by performing, well,
whoa. So I want you to think a little bit, remember logic thinking. Okay, so when you're in the patient, okay, and you think that you have a possible malignancy, what do you remember the GYN oncologist is always doing first? Do they just, bam, go to the periaortic lymph nodes and start plucking away?
No.
So first they put their hand in, right? They put their hand in and they feel what? They feel the liver, they look around the bowel, they assess the patient. Right? They do it systematically. So I don't know if this is, I've actually never seen this case, so I don't know if this is what Dr. McSherry wrote down, but one of the things first is you want to do an inspection of the lower and upper abdomen.
Okay.
Okay? Then definitely you want to do any peritoneal biopsies, an omentectomy, an appendectomy, and a pelvic and periaortic lymph node dissection. And that's what the GYN oncologist would do. But don't forget to talk about how first you're going to assess the patient, because you're just not going to jump in and start like bailing away at the aortic lymph nodes, right?
Right, no.
Yeah. Good. Okay, so we can go on here. Okay, and then how would you, this is, I think I looked at this answer, how would you treat this patient after surgery? This is a really tough question, actually. You might not even remember this from residency.
As far as chemotherapy or?
Well, I mean, give me your best answer as to how that you would treat, like let's say this patient came into the office and she was on the schedule for this happened to me last week. Okay, I had a patient exactly that had an ovarian malignancy. The patient showed up and the GYN oncologist had called in sick that day to the office, but the patient drove 3 hours from Maine to come to see this GYN oncologist in Boston, and she wanted her appointment. She didn't care if it was with me or a GYN oncologist. So guess who got to talk to her about her treatment after surgery?
Oh, you.
Me. So how would you talk to the patient? Give me your best effort to talk to a patient after surgery.
So I would say to her that the pathologist found the frozen section to be a yolk sac tumor, and a yolk sac tumor has a survival rate that's very good, greater than 80%, and disease-free. And then I would say to her that we're going to use, oh, here it is, endodermal sign is aggressive, so irradiation as well as chemotherapy. So I would tell her, yes, we're going to irradiate your pelvis. We're going to send you to a radiation oncologist, and they'll be able to tell you when you should go for your radiation for your pelvis. Chemotherapy, you'll be using chemotherapy. And I mean, I would have had to look it up before I saw the patient, but it's saying here vincristine, actinomycin D, and cyclophosphamide is the treatment that they're going to use for her.
Yeah, I think that that's all, you know, really good, but I think that, you know, you could have said it a little bit better as a GYN, as a generalist. So you can tell her, remember they love in the boards that you take, like, really good care of their patients. So one of the things that, you know, the way I would say this, and, you know, you can do always things differently than me, but I said to this patient, you know, the preliminary pathology did show a malignancy of the ovary, and this is something that is going to require further follow-up therapy. Here at Leahy Clinic, we take a multi-team approach to treating you as a patient. We're going to have you see a medical oncologist. It's going to talk to you about possible chemotherapy and radiation. You're going to see somebody who specializes in the different support groups that are offered to women who have ovarian malignancies. You're also going to be rescheduled with your GYN oncologist so that he can go over the specifics of the surgery with you. And as a benign gynecologist, I'm happy to be totally involved in your care and help coordinate all your appointments together.
Nice.
So, I mean, yeah, I mean, believe me, I have mastered the art of, like, you know, spin doctoring, okay? But that's how that, I mean, see, like, the patient actually thinks that she's cared for, and you really haven't done much for her. And I haven't, you know, done anything about vincristine, actomycin, BEP, and VAC. I mean, that's what Dr. McSherry, those are the correct answers, you know, on there, but you also have to convey that you're caring for the patient. You're not a GYN oncologist, but you can still do something for this patient.
Sure.
So that's a good way to think of sometimes some of your answers that you might not know the answer for, you know, with the board examiners, is just make them think that you really care.
Right, right.
I mean,
Which I
you
do. So, yes,
of course you do.
Yes,
yeah.
Of course.
No. I mean, like, you do. I mean, we all do as doctors. So, I mean, I think those are just the references. And I, like I said, I think that as a benign gynecologist, if you don't practice a lot of GYN, you know, look up some things in Williams Gynecology. Don't be shy.
Yes, definitely.
What questions do you have any questions for me about the exam or anything you wanted to ask since you have me on the webinar here?
Yeah, just a quick question. So, do they ask like anatomy, like to tell me the course of the ureter?
You know, I didn't get asked a lot of anatomy questions, I'll be honest with you. I think that it's definitely something that you need to know, and that they're going to ask you that maybe just to kind of start off with, and if they get a feeling that you know your stuff, like let's say that you started to sound really smart, you know, okay, the ureter is about 30 centimeters long, it courses over the psoas muscle, in the medial, you know, once you start talking the talk, then they'll be like, okay, now tell me about how that you manage this ureter injury.
Great.
Once that they kind of have their check mark, that they feel that you know what you're talking about, they kind of move on.
Okay.
Anything else I can answer for you?
Thank you very much, and thank you for asking me all the questions. That was great. Because now at least I'm going to start studying at a certain point, so that's good. That's good.
You should be studying every night.
Oh, I do. But
okay.
I mean, like, I'm going to study more like the specific questions, and like you said, make things compartmentalized. So, you know, infectious. So, like, just, you know, exactly. Because sometimes when you get nervous, you just start rattling off things, and it doesn't sound organized.
You do. You start rattling off, but if you think in terms of compartments, it helps a lot.
Yes.
And, you know, that helps with obstetrics, too. Like, when you think about it, you know, if you think about, well, what are the causes of IUGR?
Right, maternal,
okay, it
fetal,
can be maternal,
placental.
fetal, placental. You got it. See, you're already, I mean, that's the way to go.
Okay, excellent. Thank you so much. I appreciate it.
Oh, no problem. Good, awesome. Hey, Liz, you're available to do mock orals over the phone, right? If people want to just work with you privately, like a private instructor?
Of course. Yeah, no, and I like it, too. I think it's a lot of fun, too.
Yeah, absolutely. And these cases of the day are not available out for everybody. I keep them as a part of a file. If you want to listen to it again, you're more than welcome to go back and look at the webinar. The webinar is available up to 90 days. And then tomorrow night we're going to be doing twins. I'm going to be announcing what the topic is every night. I'm just going to try to mix things up. I wanted to be a surprise to everybody. So Liz is available for mock oral. So is Dr. Walton and Dr. Doe, and also Dr. Modi's available. We do have a new examiner this month, Dr. Ramirez. He passed his boards 2 years ago, and he's like my new Farnham. He's a urogynecologist, and he loves urogyne, so we'll be doing a lot of urogyne with him. Liz, again, thank you very much. And you're still doing caseless, Liz, at all?
Yeah, for the people who are the latecomers, get them in, and, you know, usually I can, if you just give me like a couple days advance notice, I can usually get a case list done in a night. I mean, if you just give me some notice, I'll cancel my social plans.
Okay, thanks, Liz. Thank you so much. Okay, this is Dr. McSherry concluding tonight's webinar. It is 10:10 p.m. on August 4th, 2014. This webinar will be available to listen again and again and again in about 24 hours. So all you have to do is go back to your original invitations you received from me, is click on the webinar again, and you can go back and listen to it as many times as you like. These are very high-yield webinars, and I just want to make it available to everybody. If you would like to have a time to go ahead and have a mock oral online, feel free to send me. I can put you on a first request list. That's not a problem. I want to everybody to take care tonight, and I'll see you all tomorrow. This is Dr. McSherry signing off. It is 10:11 p.m. on August 4th, 2014. Thank you.